Okay, so why don't we continue on with the anterior compartmentation? What do you think of this case?
There is patella alta.
Yeah, so you don't need to make any measurements here.
Yeah.
Yeah, so that's patella alta. Okay.
Okay, so here again we have patella alta.
Yeah,
Uh,
what's this little thing here?
As you notice, it's a female, and usually the altas are in females,
Okay.
most commonly.
There's subcortical bone injury. I mean, uh,
Yeah, it's probably chronic, kind of low in signal intensity.
mhm.
Why do you think that is there?
I mean probably from irritation from the patella alta.
Yeah, so it's a kind of an impaction injury that you can get when the patella goes up here. Actually, this is the articular component. This is cortical here. So often what will happen if you have a significant patella alta, the inferior cortical bone or the inferior pole will impact against the anterior cortex of the uh, distal femoral metaphysis, and you'll get kind of kissing injuries here. And we'll see some that often presents with deformity of the shape of the femur in this location, and persists on to chondromalacia extending down into the trochlea as well as the inferior pole of the patella. Okay, great.
That's not a good kiss, by the way.
So we have sagittal views of the knee. We can have patella alta. Looks like there's a thinning of the chondral cartilage there. Um, so probably severe grade 4 chondromalacia.
Yeah, so now you have to be a little careful here, but I think there is grade 4 chondromalacia down in here. This area here is actually cortical bone. This is cortical bone. The cartilage goes from there to there. So often with these patella altas, what you'll get is degenerative disease here, where you have cortical bone impacting cortical bone that's not supposed to impact each other. But this can be very painful and cause symptoms in patella alta. Uh, and frequently,
John, does
yeah,
the trochlea get more of a injury than the patella?
I think that varies a lot. I can see, I've seen both. I've seen where the trochlea is much more damaged than the patella, where the patella is much more damaged than the trochlea. You know, I would say that for these congenital diseases, it can be either way or both.
You have an axillary view in this?
I do not have an axial, no.
Oh,
Yeah, it would be nice to, but what we would see would be the bone connecting here, and you get a lot of remodeling, and you can also see that we've got old Osgood Slaughter disease here as well.
yeah,
Now,
that's a problem.
and then when you get these bone injuries like this, you will very frequently have large inferior poles. This is the inferior aspect of the articular cartilage. This is the articular surface. All this from here down is a prominent inferior pole of the patella. And when you have prominent inferior pole of the patella, it acts as kind of a leverage arm, and you get a lot of stretching and injury to the patellar tendon, and you'll commonly get patellar tendinosis here at the inferior pole at its attachment. In this particular case, we have injuries, chronic injuries distally as well. Okay. Robert.
All right. Let's see. I'll patella also on this one. Might be even a little bit low.
Speak up, Bob, I can't hear you.
Sorry, can you hear me?
I can hear you, Robert.
Okay. Uh, so I don't see any patella alta on this one.
So what we okay, so what we see here is actually the patella. Normally, the articular surface of the patella should be pretty much parallel to the anterior cortex of the femur in the extended position. And then when you flex the knee, the patella is pulled downward and rotates around the trochlea and comes more in this kind of an angulated appearance. But in the extended knee, the long axis of the patella should be collinear with the long axis of the femur. So this is abnormal. We actually, if you did all the measurements, you'd find this would be a very long axis here because we got a big inferior pole, a short patella. So the what's that ratio that we talked about last time? And Sol-Savati ratio would be very abnormal. And this is patella baja, which we like to call Yergudis disease, since John was the one who coined the term patella baja a few years ago.
Baja is a small town in Mexico, just south of the border.
Mm-hmm. Okay.
It doesn't mean anything.
So patellar instability surgeries, there are a lot of surgeries. In the acute setting, you can have ligament repairs or graft placements. And the chronic, we talked a little bit about lateral release, which is not performed very often anymore. We talked about I think, we talked about the Rue Goldwaith procedure.
We haven't, but it's no longer done.
Yeah, but we'll talk about it because you may see it in older individuals.
It's been replaced by another procedure that's very similar, but much better. It's a longo procedure.
Okay. And then we'll talk about surgeries you can do to the tibial tubercle, like the Maquette procedure and a host of others that are very similar. And then some potential things you can do with the trochlea, which really aren't done. So
The thing about I'm sorry to interrupt, John, but the Rue Goldwaith procedure or the longo procedure, the bone is not involved. It's mainly done in children that sublux or dislocate. So it's an all soft tissue type of repair. The others like tubercle and so on, Maquette, that's all bone procedures.
thanks, John.
And
We'll go through those.
I've done quite a few Rue Goldwaith. I've never had any problems with them that I can remember, but I like the new one much better.
Thank you. Okay, Tayson, this is on 6/25/04.
All right, so it looks like there is a qual of a transient lateral patellar dislocation.
Okay, so we can see the characteristic anterior lateral subcortical bone traumatic injury, typically seen dislocations. The axial image, what do you see?
The medial patellofemoral ligament looks like it's
Yeah,
torn.
it's kind of disrupted there. Okay, so this is patellofemoral ligament avulsion. Okay, so this is on 6/25/04. Now let's go up to 4 years later. This is what it looks like 4 years later.
All right, so it looks like there's been a medial patellofemoral ligament reconstruction.
Okay, all right. And you can see the 3 suture anchors here that reconstructed that. That's good.
What do you think about the patella and the trochlea in this case?
I mean, the trochlea is very dysplastic.
Yeah, we're not quite.
Do you think that procedure has helped the patient?
Um, you know what? I don't know on this static image.
Maybe
I have my doubts about that.
okay. So this was one form of patellar femoral ligament repair where the tear is close to the patella in this particular patient. Okay.
Okay. 19-year-old, pain after surgery. So, okay, I see some surgical material there. What side? Is that the medial
Yeah.
femoral condyle? This, uh, yeah, I'd have to see more. I'm not quite sure. Okay, so maybe part of the medial uh, patellofemoral ligament, maybe reconstruction.
Okay. And here we can see something out here
Mm,
coming all the way over. Now let me go back here. So this is the medial patellofemoral ligament graft. And you can see that here it is. Let me see. God, sorry about that. Let me get it here.
And what's the problem here, Robert?
Well, this is Elior's case, but here you can see it out there, and then here.
Um,
And notice
you
it
see
moves.
that screw goes into the femur, and the medial collateral ligament, patellofemoral ligament, does not attach to the femur. It's superficial to it. It's a soft tissue type of attachment. So, um, by putting that right into the bone, um, that really restricts things.
Right. Yeah. So we've seen a number of these medial patellofemoral ligament grafts, and the situation here. Here you can see that this is actually the tunnel for the placement of the graft on the femoral side. And as John was saying, to put these grafts in, you can't really put a graft to a soft tissue structure, so you kind of have to put it into the bone. But if it's placed in the anterior half of the medial femoral condylar area, then what you have is a very short distance between where it attaches to the patella and where it attaches to the femur, and it doesn't allow for much motion. So you like to put these in the posterior third. That means they're longer. It will restrict the movement less and is more likely to be physiological functional than if
Yeah,
it's
well,
thermal
it
tunnel.
stretches out with time, so you get more motion, uh, and not as much as restriction. But I've never liked this procedure. I've never done it. Right.
So, 18-year-old female with knee pain 1 week after a soccer injury. So it looks like there's quite a bit of heterogeneous signal within the medial patellofemoral ligament. So a partial tear. Is there a complete tear there, or is there just a partial tear?
It's pretty much a complete tear because this patient had a patellar dislocation. So in this case, it was really probably a complete tear. And we see a lot of degenerative disease, a lot of chondromalacia, a lot of dysplasia of the anterior compartment. So what do we see here now?
So it looks like this is post-surgical repair of the medial patellofemoral ligament. They're anchoring in the medial femur.
And what's this up here?
Looks like that's where it attaches to the patella.
Yeah. So this is a medial patellofemoral ligament graft. So there's the graft placement, and the femur. It's too far anterior, and then if you go back to the patella, there's the placement in the patella on the medial side, and here again we can see the patella attachment site and the femoral attachment site. And this was a 7-year study published in 2007. And it showed that these medial patellofemoral ligaments really didn't work very well. But it's believed by some people that they didn't work very well back at that time because the positioning often of the femoral component was too anterior, which restricted motion too much. And a lot of these people would then tear the graft to get their motion back.
Is the
there's a much better procedure by using the quadriceps obliquus uh, muscle and bringing it distally and superiorly attaching it to the patella, and that works pretty well
Well, that's
from
good.
preventing the patella from um, riding in the wrong direction.
Well, good. I don't think I've seen any of those. Did you have a question, Ted?
Yeah,
Well,
I was
that's
wondering.
that's part of the root Galway procedure, and the new one.
Okay,
You do a lateral release, you do the advancement of the obliquus, and you take a third of the patellar tendon on the medial side and split it, and then attach it to the um, tendinosis tendon, uh, uh, posterior, medial distal, and that's been like I said, to replace the root Goldweight, and that works pretty well. It's recommended
good.
probably for adults as much as the kids, although adults usually get a bony procedure.
Okay.
I was wondering that last reconstruction, there was a tunnel with the anchor all the way on the lateral side.
Talking about
Is that,
this?
yeah, is that a,
This is tunnel here. This is a suture that comes around here to try to supplement the anchor strength.
okay.
And you tie it to the bone with sutures.
All right.
Okay.
So it looks like there has been the graft with the anchor at the medial femoral condyle. It looks like the fibers are disrupted.
Right. And here we can see the disruption there, and so that's a
17 years old.
graft tear. Yep.
Okay, so here I'm seeing a defect in the, I mean, is that the lateral side?
Yeah.
So, yeah, is there a lateral retinaculum?
Yeah. So that was a
Yeah, that's the lateral side. You can see the lateral condyle higher than the medial condyle.
yeah. And notice you still have lateral placement of the patella, even though they've released the lateral patellofemoral ligament. Good.
Female college athlete with anterior knee pain for 5 months after lateral release. Looks like there's a little patella alta,
Okay.
and looks like
It's
there's
kind of borderline. This could be just about the lower third, but I think there's a little borderline patella alta here. Yes.
and then looks like there's some edema in the superior part of the papa's fat pad.
So on the lateral sides, we see a lot of scarring here.
I think I'll agree with it.
It's good. Thank
Um,
you.
I think you're the guy that described to me what your thoughts are on the patella alta, and that you said that the articular surface of the patella distally should be meeting with the trochlea, right
Right.
at that level.
Right.
If it's distal, then it's patella baja. If it's proximal too much, then it's alta.
Right.
Am I quoting you correctly?
Yes, you are. Yeah.
Good.
Good. Yeah. And then here we can see, as Greg said, we have scarring and the superior lateral aspect of Hoffa's fat pad. If we look on the axial images, we have a shallow trochlear groove, a large lateral facet, so we have some congenital dysplasia. And this is scarring. This is after a lateral release, but this is a patient who has patellar instability and Hoffa's fat pad impingement syndrome, which you can have in the same category. Okay, Robert.
Let's see. Looks like we have patella alta, it's pretty extensive condylomalacia. And looking at the patellar tendon, it almost looks like there's a second band of it posteriorly.
And is this pre or post surgery?
This is post-surgery.
Posterior.
Well, I know that, John, but
Oh, you're
Assuming they had a
you're asking
procedure.
Robert. I'm sorry.
I'm asking Robert.
I'm
Yeah.
sorry, my error.
Assuming it's post-procedural.
Okay.
Where do you think that posterior patellar tendon portion goes?
That's a good question.
Laterally or medially?
I'll say laterally. Don't know for sure.
No, it goes medially. You want the patella dislocates laterally, so you want the patellar tendon to go medially to pull it in the medial direction.
So if we
This
go
is
to,
almost like a Rube Goldway type of
yeah,
procedure.
so if we go here, we can see uh, that tendon there, and if we follow it down, it kind of comes. This is the lateral side. It comes underneath, comes all the way across over here, and then it's attached to the medial aspect of the anterior tibia. And this is the Rube Goldworth procedure. That's what it looks like. So, John, you want to tell us about how you did these?
One of the procedures is like you're looking at here. You take the patellar tendon and you take the lateral side and you split the patella and the lateral side goes medially and you I used to use a staple on unless it's a child and then tack it to the bone. Then you do a lateral release also, not a long one like we ordinarily do, but just a short release of the patellofemoral ligament, lateral, and then you do a quadriceps obliquus, and you advance that and distally and superiorly over the patella and tack it down to pull it laterally, to pull the patella medially, and that's about it.
Good.
It's a fairly lengthy procedure, but it's in children. It's pretty rewarding. It works pretty well. But this new procedure, I like better.
Okay.
Although I've always liked the Rube Goldway procedure, but
Okay. And then there's a whole host of tibial tubercle osteotomies where you basically do an osteotomy, you remove the tibial tubercle, you tend to move it medially, so it's got more of a medial placement. You also will often do your cuts obliquely, so when you move it medially, it also moves it anteriorly. And when you do that, you have more of an anterior pull on the patella, which decreases the pressure of the patellar articular cartilage on the trochlea, which is thought to decrease the risk of developing chondromalacia of the patella and trochlea.
this one looks like a Emsley Trelot procedure that I did it independently from these guys. I met them in a bar in San Francisco and had a nice talk about how we did these, and we were pretty close to how we did them.
Good.
You don't. What you do is you undermine the patellar um, attachment to the bone, maybe a sliver of bone about 1/8 of an inch, and you break it over. At least that's what I do. I break it over to the medial side, and then tack it down with a staple. Um, this is 2 screws. I have a little problem with screws in this area because the tubercle will break.
Okay. Alrighty. So let's see. Tayson, are you next?
Oh, by the way, you also do a lateral release with that.
All right, so I see susceptibility artifact at the tibial tubercle, so probably an osteotomy.
So we already have grade 4 chondromalacia. There are the axial images. And
Yeah, complete cartilage
so
loss,
this
lateral
was
set.
probably a little too late. They already have a lot of
Yeah.
disease, but this is a patellar realignment procedure, which was a osteotomy of the tubercle. Then. So a lot of these at this stage are to try to decrease pain.
Mm. Okay. Yeah, a lot of maybe some degenerative change at the patellofemoral compartment. The patellar tendon looks thin on that slice, on that sagittal.
Not right in the middle of it.
Okay. I'm
Okay,
not
so
quite
this
sure
is on
what.
7103,
Uh-huh.
and now we'll come back 7 years later, and this is what it looks like.
Yeah, the tibial tubercle, a deformity of it. Maybe there was an prior osteotomy.
Okay, so here's the osteotomy side.
That's a maquette procedure.
You do it obliquely, so when you start to medialize the tibial tubercle, it also goes anteriorly to decrease the pressure, and then you allow the bone to heal back in this position, and this is a maquette procedure.
Yeah, the idea of this is to bring it anterior. You put a graft posterior to the tubercle, and you put the basically the attachment of the patellar tendon with the bone anteriorly. And the problem with this procedure is that it's not very often done. I don't know who doesn't anymore, but it can really bleed like crazy. And the problem is you can get so much blood down into the calf and so on that you may even lose a leg. So I've never done one of these. I don't see any reason to do it. But some people think that you take the pressure out the patella. I don't think that's true.
Okay, good. Great.
History of recurrent patellar dislocations with tubercle alignment. So we have two slices here of coronal view, I guess.
That's why we can see all the metal artifact here.
Yeah, that roundish, ovalish metal artifact. And then you see, I guess that's a screw. Is that a screw there on the sagittal?
Yeah, the two screws
Wow,
here.
Two screws, okay.
you don't need that.
You can see the bone edema here
That's,
from the dislocation.
that's overkill.
Okay, you hear that? So
Well, if you look back on that, John, there the tendon has been split longitudinally and put that posterior structure that you see that's from the lateral side, and it's brought medially.
And here we can see that. We can see a lot of edema here. Acute bone marrow.
Whether the bone has been moved or not, I can't really tell for sure.
And here the
It must be because they're using a screw or something to fix it.
So on the axial images, it looks like there's disruption of the medial patellofemoral ligament. Looks like the patella, or yeah, chondromalacia there. Patella looks like it's kind of laterally displaced.
Yeah.
And there's edema on the left.
So even before the surgery, they had an acute dislocation in this patient, and you can see the patient has congenital dysplasia, which has led to all of this problem. Robert.
All right, 36-year-old male with anterior knee pain. See a couple screws in that proximal tibia.
Okay.
Some grade 4 chondromalacia, I think patella, medial facet there.
Okay, this is 6/19/09. Now, this is a few months later. They operated on this patient because he had anterior knee pain. And so here's the previous one. And now, so what do they do?
Looks like they removed the screws.
Good. So they remove the screws here. This is on 10/12/09. Here we can see they did put in a medial patellofemoral graft in that location. But then the patient came back with increasing symptoms a month later, and this is what it looked like.
Looks like there's some edema where those screws were previously pretty extensive.
That's something to the tubercle here.
Yeah. Yeah, so this is then an avulsion of the patellar tendon. They removed the screws, and now the tendon basically tore and is unstable again.
I don't understand these people because the screws just won't hold soft tissue. Doesn't make sense to me who these guys are.
Well, wasn't a happy camper. And then finally, there are bone procedures that have been described to change the shape of the trochlea. I've never seen one of these done. They have a lot of complications. It's very hard to get the trochlea and the patella to align properly once you change the shape of the other one, but they have been described in the literature.
Not done anymore that I know of.
Yeah.
Now you try to replace the trochlea with artificial metal.
Yeah. Okay.
You sort of do a total patellofemoral replacement or a partial.
Yeah, unit compartment.
And some of them are quite good.
Yeah, most people just go to a total knee if they need to do that, though.
It depends on age, John.
Yeah. Okay.
All right, on these axial and sagittal, I see focal edema in the Hoffus fat pad superolaterally.
Okay. Patella alta.
Yeah.
Maybe a little shallow trochlear groove. And then this is typical findings we see in patellar tendon lateral patellar friction syndrome, maltracking due to patellar instability. And we just see this very commonly now that we know what to look for. So I think this is a much more common cause of anterior knee symptoms than we ever thought in the past.
Some of these are just post-trauma.
Yeah.
Yeah, looking at the lateral retinaculum at its patellar attachment, there's some edema, maybe partial tearing. There's some laxity of that lateral retinaculum as well.
Yeah. So this is another impingement syndrome in that same area that can cause painful clicking. Yeah, right. With a lot of edema in the soft tissues.
Okay.
46.
Some clicking is normal in the knee and some is not. The clicking that you hear, if it's tender and painful, that's abnormal. But the clicking, if it's just non-painful, that's perfectly all right.
Thanks.
46.
Knee pain for 2 weeks.
So we have sagittal images and one axial image. It looks like on the non-fluid sensitive sequence, it looks like there's.
I can't hear you, Greg.
Sorry. It looks like on the these are the T1 sagittals, right? Looks like there's kind of dark signal in the office superolateral aspect of office fat pad
Up in here.
there, and then kind of a little bit of you kind of see it on the other one.
Okay. So large. Yeah. Maybe a little patella alta, large inferior pole here.
Yeah.
Maybe some edema in that area. This is over a little bit farther on the fat suppressed sequence.
Yeah, so you can really see the edema and superlateral aspect of office fat pad. And then you can also see, yeah, so it's a perforations in here.
Yeah. It's often called office fat pad impingement, and you get pain clicking in that particular area with tenderness. And histologically, you have inflammatory changes and scarring in the area of edema in the fat pad. And you can also get cartilage damage and bone damage with it. Here's a 33-year-old female, had a fall that probably started everything, had a little bit of patella alta, and here you can see the edema in the superlateral aspect of office fat pad. So typical appearance of office fat pad impingement syndrome. Okay. So what is the relationship of patellofemoral alignment and trochlear morphology to upper lateral office fat pad impingement? All these changes correlate with increased risk for pain and symptoms in this particular area, as well as patellofemoral osteoarthritis. Okay. See, Robert, did you do the last one?
No, I think I'll.
Okay, you're up.
Looks like the patella's laterally subluxed. Some grade 4 condymalacia there. And then looking at the medial patellofemoral ligament, looks like that may be disrupted, but I don't probably want to see it on some more.
Okay. And here are the sagittal images. So that's a lot of what we've been talking about. In this case, you've got lateral tilt to the patella, kind of an extreme case. You've got lateral displacement, got a chronic tear of the medial patellofemoral ligament, and then patella alta with the degenerative disease where the two bones are contacting each other where they shouldn't, and no contact between the articular cartilage of the patella and the trochlea. So kind of a severe case. This is on a low field scanner. So even on low
And
field
the,
scanners, you can see all this stuff.
the tibial tubercle doesn't look so hot either.
Right. And here we can see lateral downsloping, severe degenerative disease, congenital dysplasia of the anterior compartment, all the eburnation of the subchondral bone. This is also called lateral pressure syndrome in these patients.
Why they use these new terms, I don't know, but it's all right with me if they want to.
Well, the problem is that there are many different ones, and many different names for the
There's so
same
many,
syndrome.
yeah,
It's confusing.
yeah. The more verbiage you have in orthopedics, the more confused the orthopedic surgeons are. And we're easily confused.
I don't think so. Okay, Tayson, what do you think of this case?
So looking at the anterior subcutaneous tissues, there's a area of higher intensity. I don't know, was it in a bursa? Superficial infrapatellar bursa?
Okay, so this is frequently called pre-patellar bursitis. This is almost always due to contusion with or without hematoma in the subcutaneous tissues anteriorly. You saw a kind of an extreme example earlier today. I think you guys all saw it that Natasha had. And in more severe examples, with a glancing blow, you'll get a separation between the subcutaneous fat and the deep fibrous layer that it should be adhesed to, and that can fill with blood. And what's that called?
Scarpus. You talk about scarpus fascia.
Yeah, scarpus, Morel-Lavallée lesion. Yeah. So this could be due to infection and be a true bursitis. Most of the time, this is actually just post-traumatic injury with hematoma formation. I prefer to call it. I prefer not. No, occasionally I did today actually use the term pre-patellar bursitis, but I don't like using that term in a report. But most radiologists do when they see this. I just described it with a history of trauma like this is subcutaneous hematoma within the soft tissues, give kind of the size and the thickness and so forth.
If it's mostly just fluid,
Yeah,
it's mostly just simple fluid. What do you call it then?
if it's just simple fluid, usually if it's an acute setting, it's going to be associated with a lot of edema around it. It's going to be indistinct. I guess if it were chronic simple fluid, which I've very rarely seen, then you could think about maybe it being well, could be a
That's a,
bursal fluid collection. But if you had true bursitis, you're not going to have just fluid. You know, the true bursitis would basically be an infection. Yeah.
well, you have proteinaceous stuff in that fluid, isn't there?
Yes. This is
I'd probably stick a
resolving
needle in
hematoma.
there.
Yeah, this is
I'd,
resolving
see.
hematoma. Yeah.
I probably would stick a needle in there, try to suck out some fluid. If not, I just make a small incision and remove the whole bursa.
Okay.
And that's a cure.
Okay, so here looking at the pre-patellar soft tissues a little more superiorly than the last case. We see some soft tissue thickening.
It's a little different.
Yeah, yeah, it's a little darker signal than prior. What are we pointing at there? I don't know. I don't know.
Yeah, it's just showing the fluid collection inside this.
Okay.
And then, you know, the coronal images can actually get us, you know, there's just multiple different signal intensities in this particular lesion. And this is all different stages of hemoglobin metabolism. And this, you can call this hemorrhagic pre-patellar bursitis. But I prefer just to call these subcutaneous hematomas
Okay.
and put it in the category of Morel Lavallee lesions.
Axial and sagittal views of the knee. It looks like there's fluid levels in the suprapatellar or prepatellar soft tissue. So this is like the Morel Lavallee, right?
Okay, so this is just a big hematoma with fluid level, with a hematocrit fluid level in it. And it's really a separation of the deep fat from the deep fascia here. And this is a Morel Lavallee lesion. John, do you want to tell us how you treat Morel Lavallee lesions?
These are a little harder to treat than just removing a bursa. What you do here is you open proximally and distally a small incision, and then you use a water brush. I don't know if you guys have ever seen one, but it's like scrubbing a bottle of water. You just take the water brush and try to remove any scar tissue that has formed there, and get some raw tissue, and then irrigate it for quite a while. And sometimes you'll have to admit the patient to the hospital and irrigate it for there so and on antibiotics because some of these can get infected very easily.
Okay, and then the issue is really to try to get the subcu fat to adhere back to that basement membrane, which can sometimes be difficult.
Yeah, what happens is you form a membrane and then you suck out the fluid, but the membrane remains. So it's a little harder to treat than just a bursitis, because the bursa, you remove the bursal tissue, the soft tissue that envelopes the water, and it's cured. With this situation, it's not cured. If you leave any any tissue behind.
Okay, good. Okay, Robert.
All right. So looking at the pre-patellar soft tissues, it looks like there's this large collection or mass-like soft tissue swelling.
Okay, up here.
Considered for bursitis.
So I bet you want an MR, right?
Yeah.
So sometimes you get what you ask for.
It's pretty heterogeneous there. There's some
Okay, that's a T2. Here's a T1.
it's a little more.
Here's a PD fat sat and a T2.
Is that all just hemorrhage?
Yeah. So it's very kind of a complex kind of signal. Heterogeneous mass, no bones jumping. So this was called hemorrhagic pre-patellar bursitis. It's also known as housemaid knee or washerwoman's knee. May be swollen, painful. It's usually caused by a direct blow on the knee, but could also be due to chronic kneeling, like you're doing some washing and so forth. Also can be caused by a chronic infection.
Carpet layers also get this problem.
Yeah, right. And it can be due to chronic repetitive trauma with irritation of the pre-patellar bursa. And here you can see the other bursas that can be around the knee, which will do this. So this is probably chronic. You know, you can see that it's been there a long time. There are a lot of low signal intensity areas. These tend to be very tender, but this is more of a chronic issue. So it's really kind of a chronic Morel lavallée type lesion that's not treated early on. And again, this is difficult. You have to remove all this tissue and do what John was talking about to try to get it to heal properly. Okay, Taysom.
All right, so it looks like we have some slight patella alta, prominent inferior pole, and deep infrapatellar bursitis.
Okay, so here we have all this fluid in the infrapatellar bursa. The infrapatellar bursa is usually a very small little bursa. You can see it in most patients with a little bit of fluid in it. These tend to communicate with the joint space. But when they get large like this, they can also become painful, and this is called infrapatellar bursitis.
Okay. Again, we have patella alta. Looking at the soft tissues, I'm not seeing a pre-patellar bursitis. Okay, we're looking at the suprapatellar fat pad. Yeah, I'm not sure. I mean, could it be a plica there? That's the dark signal, or
Basically is the kind of low signal here. This is probably the suprapatellar pouch collapsed here. And here we can see that what's called the quadriceps fat pad. The fat doesn't look normal. It's kind of very dirty and inhomogeneous in signal. And what some people think is important is it's bowing posteriorly here. And this is called the quadriceps fat pad. And there's a quadriceps fat pad edema syndrome, which kind of defined as an increased AP diameter and posterior bowing of that fat pad line in this location. The problem that I have with this is if you look at a lot of knees, you'll see this pretty frequently. And the vast majority of these really aren't associated with any symptoms. So I actually think this is more of a clinical diagnosis. And I don't make this diagnosis by MR scan anymore unless there's some clinical history that there's symptoms to go along with it. Because I think all of these findings have too high a false positive rate. And I think false positive findings in the MRI can be more dangerous than false negative findings.
Do you go ahead and describe it, say mild edema in the quadriceps fat pad, or do you just?
Sometimes I do. Sometimes I'll just look at it and ignore it. If it's bowed like this, I'll usually describe it in the body, unless I think there's some symptoms associated with it. Of course, with the histories we get, they're usually not very accurate. If it's just increased kind of dirtiness to the fat pad here and the suprapatellar pouch is straight, I usually don't mention it.
And it looks like scarring of um,
Yeah.
synovial membrane, and there's also an increase, a decrease in signal posterior to the quadriceps.
You mean in here?
No, just a little more anterior to that. There's a
In here?
right there. There's a line, and almost as if the two separate, something separated there.
Yeah, the distal quadriceps is almost always separated like this. That's because there are, I think it's 7 different tendon strands that come together here to attach, and they are almost always separated as you go more proximally. I don't know that I have a slide showing that anatomy or not, but this striated celery stalk appearance is quite normal for the distal quadriceps.
Well, I'm not saying it's abnormal, but doesn't I haven't seen it that often, but I haven't seen as many as you have, John.
Right.
About 10, 20,000 cases.
Okay. Yeah. You've seen a lot.
So I surrender.
Who's next?
As
So
long as you're not Russian.
we have multiple sagittal images of the knee. It looks like the quadriceps tendon has some heterogeneously irregular signal kind of throughout. Looks like is it thickened?
Okay.
Looks like it's thickened, kind of bowing posteriorly. So then we have axial images.
There's low signal things in it.
Yeah, some serpiginous flow signals.
X-ray. There's the X-ray.
Okay, so it looks like there's like a calcified body within the tendon. So I guess it's just like calcific tendonitis.
Calcific tendonitis, distal quadriceps.
Just calcific tendonitis, that's all.
Yeah. Okay, Robert.
If it was painful, it should be a little more swollen, don't you think, John?
It's pretty swollen here. See how swollen it is? It's really
Yeah.
bowed back here.
Oh, okay.
There's a lot of swelling inside that tendon.
Yeah, a different cut there.
Yeah. Okay,
See,
Robert.
MRI is a little better, it does than X-ray sometimes.
Yeah, right.
So there's pretty extensive pre-patellar soft tissue edema. Not sure if it involves that quadriceps tendon as it kind of comes over the patella, or if it's just like a pre-patellar bursitis.
So there is kind of a debate about whether the patella is a kind of a sesamoid bone or a true bone. Some people like to call not a patellar tendon, but a patellar ligament between two bones. One of the reasons some people call this a sesamoid bone is because the anterior part of the patella is covered by a fibrous band, which is contiguous with the superficial fibers of the quadriceps and the patellar tendon. That doesn't go to the inside, obviously, but on the outside. So many people will call it a patellar tendon. And if it's a patellar tendon, then we're really dealing with a tendon that has to do with the quadriceps here, and this would be kind of a sesamoid bone within the tendon. But anyway, this is called the quadriceps expansion, this area of fibrous tissue here, and this was a focal tear in that expansion, which produced symptoms, and then it heals nicely with conservative treatment. Okay, Robert?
Treatment is immobilization.
Thanks, John.
Let's see. So it looks like there's some pre-patellar fluid. Yes, don't see all the fibers of the quadriceps kind of attaching there at the superior patella. Looks like that's disrupted there.
Okay, and then here we can see that there's a lot of signal actually within that quadriceps tendon, and this was a high-grade partial tear of the distal quadriceps tendon. Okay. Jason?
Robert, what would you do with it?
I would refer them to surgery.
Well, if you're a little aggressive, you probably suture that area back in place. If you got a lot of guts, you put it in a cast or a immobilizer. I would probably suture it, and I'm conservative. So because I'm afraid that this person will just overdo it and tear it. Once you tear it completely, the recovery is far longer than if you suture it back.
Thanks, John.
I mean, I'm talking about 6 to 12 months.
Yeah. Okay, what do you think, Tayson?
So, looks like there's a full thickness defect, distal patella. Distal quadriceps tendon, sorry.
Yeah, we'd want to go see if it goes all the way medial and lateral as well, but that was a tear. And here's a complete quadriceps rupture, in which case the quadriceps will retract superiorly and the patella will often fall inferiorly. Quadriceps rupture.
Not that uncommon.
Yeah.
Here the quadricep tendon looks pretty intact. We'd see edema in the vastus medialis. Maybe a muscle, yeah, a low-grade muscle strain.
Yeah, and here's another one. So these are vastus medialis tears. Why don't we finish on this one, right?
So 25-year-old NHL All-Star with skate laceration without tendon injury. So it looks like the quadriceps tendon's intact, but there's just focal edema, or I guess a laceration there in the anterior muscle fibers. Yeah, then on the axial, looks like, there you go.
So this guy was kind of lucky. The skate went all the way in and lacerated his quadriceps, but when it got down here into the nerves and veins, he was okay. It came very close to producing a more serious type injury, and there you can see the laceration coming down through the proximal thigh. And so you do an MRI scan looking for foreign bodies.
It went with the fibers in the same direction. So
Yeah.
he is indeed lucky.
Yeah, and the neurovascular bundle was intact, and we saw no foreign bodies with the MR. Okay, well, why don't we stop here, and we'll continue and finish out the tendons section. Let's see, John, I think we're going to go ahead and Robert, we're going to go ahead and have lecture tomorrow. I'm going to work all day tomorrow, so we'll have lecture again tomorrow and finish this out, okay?
Okay, hold on a second. Let me get that number for you.
Okay. Thanks, everybody.